Hello and welcome to the recall session for the INI from November 2025. We're long overdue with this. I'm so sorry I was covering the NEET and a couple of review lectures before, but I had the pleasure of interviewing some of the toppers from the INI session. Most of them said that the paper was definitely answerable from, in the most part, from our previous lectures. So thank you. And but there were a few doozies. I feel a lot more importance has now started to be given to neuroradiology, and we should definitely review the neuroradiology sections. And I'm definitely going to create an atlas of neuroradiology now, because it has become the most important differentiating factor between those who are getting through and who are not getting through. So, to an extent, operative, but a significant portion has gone to neuroradiology, both in the NEET and in the INI sessions. Now, for the first question, there's a clinical scenario which is suggestive of post-dural puncture headache, also called intracranial hypotension. And it's on post-op day 1. The most clear MRI finding is what? This is a real bouncer, because it's either come in a previous paper. Otherwise, I don't think general neurosurgeons in general would actually think of post-dural puncture headache as the most important question in neurosurgery. We often see both post-dural puncture headaches, and because we open up the brain repeatedly and drain CSF practically, we do scans on post-op day once sometimes, especially in the private practice, and we almost always see an enhancement of the dural attachment. That is the most common finding. It is the fastest finding, but it is still documented to occur usually within 3 days of the post-dural puncture headache. So the more important finding would be a slit-like ventricle. This has not been mentioned very commonly. I've seen Radiopedia, I've seen papers. A lot of them don't mention slit-like ventricles as the first finding. Very honestly, on post-op day 1, it will take a long time for the enhancement to come. Remember, it's enhancement. So it is this pachymeningeal enhancement is something that happens when excess blood flows, which takes contrast onto the dura. It will take time for the dura to actually be involved with this, whereas slit-like ventricles will happen immediately, because slit-like ventricles will be there as soon as you do an LP and you overdrain the LP, the ventricle will drain. So you will see it not just on the next post-op day 1, you will see it almost immediately on a CT scan. Where there were large ventricles, they are now slit-like ventricles. The problem that happens in practical experiences, the ventricles are already very small in many patients. So a post-dural puncture intracranial hypotension will only occur in a patient who has very little CSF, a normal amount of CSF at least in the first place. If you're doing it for large hydrocephalus, you will not be able to drain that much. There will be a 200, 300 ml of CSF already in the brain. If you do it in a patient with a normal CT, those ventricles will, many times they automatically already look slit-like. So when you say slit-like, it's a very small difference. Still, I know that the answer in many textbooks will be enhancement of dural attachment. But if slit-like ventricle is given, that would be my first choice, because in practice we see that the slit-like ventricle is almost immediate after a post-dural puncture intracranial hypotension, because you are draining essentially the ventricle. Whereas dural attachment, even in books, it's written, comes in around the 3rd day, not on post-op day 1. Enhancement of ependymal lining is not an answer, because ependymal linings take a much longer time to enhance because they don't have as much blood supply as the dura itself. There are other features of post-dural puncture headaches, such as venous engorgement, something called dinosaur tail sign, and in which in the spinal cord, after the puncture has been done, the dura actually shrinks inside. Because there's less CSF between the spinal cord and the dura itself, and the epidural venous plexus, it engorges. This is like, you can imagine a cast being placed on a hand, and then suddenly when it's removed, there's a venous engorgement and it swells. This is called dinosaur tail sign. Other things are a sinking of the cerebellar tonsils, because the whole brain can then sink. There are other signs like, for example, enlarged pituitary fossa or a larger pituitary, because this also causes an sort of an empty sella syndrome kind of picture. So enlarged pituitaries can be seen because the CSF is out of that space. So I've kept this question first because it is a controversial question. It is not a commonly asked question. If you've seen this question in any established published book, then please follow the answer in the book, because I'm very, very sure that the neurosurgeon who has set up your paper is not applying that much brains. They are following this from a past paper and the answer has already been given, and they will not question the answer. They are going to consider research and stuff like that. My actual answer would be a slit-like ventricle. But I'm almost very sure that enhancement of dural attachment would have been the answer in books. So this would be the actual answer in practical terms, but this is most like the answer that is given in textbooks. One criticism of slit-like ventricle would be that because if you're doing a dural puncture, they have not said where the puncture is, but usually we assume it's a lumbar puncture. It's an LP. The LP drains CSF from the extraventricular system, from the subarachnoid space, essentially. That drains the subarachnoid space more than it drains the ventricular system. So they will say slit-like ventricles are not visible in this. Slit-like ventricle is actually visible in EVD placement, or if the ventricular puncture has occurred, and that also leads to an enhancement of ependymal lining. Still, in practical terms, post-op day 1, seeing a dural enhancement is very rare. You will see it at least 48 to 72 hours later. So this does not match this, and it does match this. But although this is much more common, this is more seen much earlier. So the answer overall is, take your pick, pick your poison. I would answer enhancement of dural attachment, because I think that would be the question. I think I've seen this question somewhere before in some book. So enhancement of dural attachment would be my answer. Although practical terms, we see slit-like ventricles much more commonly. Nature of limb in upper limb spasticity. So remember that M3 or M2 response is spasticity. It's essentially pressure on the rubrospinal tracts. So if you want to think of the nature of the limb, you can just imagine an M3 patient if you've seen it, or a posturing patient, or an M2 posturing patient. So normally we see both in upper limb spasticity, and there is definitely forearm pronation is there, wrist is flexed, shoulder is adducted, and elbow is often flexed. So although this will also be spasticity, but it will be an M2 level spasticity. Most of the time we see M3 in patients with independent spasticity. So this is seen in stroke patients, for example. In strokes, many times stroke patients are not in a comatose state, and you almost always see them like this. Imagine seeing movies like Guru or and others where they've shown patients of stroke. They almost always have their hands like this. So this is the posture, and it has been well written over here as the choice. ACA location with respect to optic chiasm, it's superior. It's please go online and check Roten anatomy of ACA. Just take see the photograph. So Dr. Roten, who passed away somewhat recently, was one of the greatest illustrators through dissections and photographs of cadaveric dissection. And the Roten's Atlas is a treasure of a book. It's one of the most beautiful books on neuroanatomy. I would put it right up there with Netter's Atlas, which is a wonderful illustrative book. And Dr. Roten's book, it is clear. I mean, I have intraoperative memory for this, but before I had this, I always had Dr. Roten's vision, which is you get the optic chiasm here, and the ICA comes here, and the ICA divides into the middle cerebral artery and the anterior cerebral artery going above the optic chiasm. The pituitary stalk comes down from here. Pituitary can be prefixed or postfixed. It can be anterior or posterior to the chiasm. If it's anterior, it's called prefixed. If it's posterior, it's called postfixed. And the anterior cerebral artery always goes above. You know why it would be superior? The one easy way of remembering this is it has to go up into the brain. It has to go towards the frontopolar region and then across the genu. If it was below the chiasm, it would be much harder for it to do, although anatomy can be anything, but it's just one way of remembering why the ACA would be superior. Secondly, also remember that choroidal branches from the anterior cerebral artery, tiny branches that go to the anterior perforated substance, come from the posterior part of the anterior cerebral artery. In fact, we're supposed to avoid these during aneurysm surgery. They go into spasm really easily. So even if you've done a beautiful AC aneurysm, the patient can end up with an internal capsular infarct and weakness. That's because you've messed around with the AC artery, with the anterior choroidal arteries, and if by chance they avulse and it bleeds, you've had it. So God help you. So so remember that it can only be present above the optic chiasm to be able to give these small branches off that go into the base of the brain. So it is going to be superior in almost all circumstances to the optic chiasm. Asterion is formed by. So very standard question. We have covered craniofacial craniometry in a chapter on anatomy, including these bregma, lambda, coccus point, Keen's point, Asterion, and how they are measured and why they are important and what they correspond to. Here I will just remind you of the Asterion. So this is basically the base of the skull. This is the mastoid bone. This is the in a skull it would be the external the external meatus, the external bony meatus, and then you have the temporomandibular joint. You have the jaw, mandible, etc., etc., etc. This is the maxilla, etc. So here you will have the lambda. All right. The sagittal suture is here. The coronal suture is here. The lambdoid suture is here. The parietomastoid suture is here. It's part of the parietal bone above the mastoid, and the occipitomastoid suture is here. It's part of the occipital bone but attached to the mastoid. Remember, the mastoid is part of the temporal bone. So it will have a joint above with the parietal bone. It will have a joint below with the occipital bone. So parietomastoid, occipitomastoid, and the lambda is essentially the joint between the parietal and the occipital bone. This meeting point is called the Asterion. Why the Asterion is important? It's because it marks the location of the transverse sinus, which is very important to avoid in posterior fossa surgeries, especially in the retromastoid approach. So if you see the same thing, you see the mastoid bone, and this is the occiput, and this is the jaw, the eye. This Asterion, just above it, it marks the starting of the transverse sinus. It's not exactly on the Asterion. It is actually in line, the surface marking for the transverse sinus is in line with the zygoma. So the zygoma to the inion, if you connect this, but you start from the Asterion, that's where the transverse sinus is, that's where it bends down to form the sigmoid sinus, and then from the sigmoid sinus to the internal jugular. So that's why the Asterion is so important. You will spend your significant part of your operative time in the posterior fossa finding the Asterion, or approximately finding the Asterion, and then putting in a burr close to the Asterion and very scaredly making sure that you do the craniotomy while preserving the bone, while not entering the transverse sinus, until you have neuronavigation where all of it just becomes defunct. So the blood supply of internal capsule, no limb or genu was mentioned. Basically, they did not mention which part of the internal capsule. They just wanted to eliminate what does not supply the internal capsule. The ICA definitely supplies the internal. MCA definitely supplies the internal capsule. Now comes to the anterior choroidal and posterior choroidal. I remember this question. I think I remember this. This was a question even in my time and when I was preparing. The answer is posterior choroidal artery. The anterior choroidal artery is a direct branch of the ICA. It definitely supplies the internal capsule. Posterior choroidal artery actually comes from the PCA. So the basilar comes up like this in front of the midbrain. This is the midbrain. This is the pons. So this is posterior. This is anterior. The basilar is anterior to this, and the basilar gives rise to the PCA, which goes backwards. This is the occiput here, and here the posterior choroidal arteries, they supply the brainstem. So they have nothing to do with the internal capsule, which is much above this. So the answer is posterior choroidal artery. The posterior choroidal artery does not supply the internal capsule. The right eye has failed to abduct in a patient with lateral ventricomyely. What nerve is it related to? Abduction of the eye is a function of LR6, lateral rectus, sixth nerve. supplying lateral. So LR6, abduction of the eye, LR6. Remember this. SO4, LR6. Superior oblique by the 4th nerve, lateral rectus by the 6th nerve, rest by the 3rd nerve. So SO4, LR6, rest all by 3rd nerve. So it's not 4th nerve, it's not 3rd nerve, something related to 3rd nerve was some choice given, I don't know. Answer is 6th nerve. The most common false localizing sign in the brain is 6th nerve palsy. If you have a rise in intracranial pressure, 90% chances are if the first palsy that will come is the 6th nerve palsy. If you go into the brain and you can see the 6th nerve, it is gone. It is one of those nerves where it's so thin and it has such a long intracranial course that if you see it, by the time you see it, it's already gone. That's because if you see it, you've probably sucked out some CSF from there, and you've gone in with a suction there and you've caused some changes there. Even a CSF suction near the 6th nerve will shake it a little bit, it's gone. All right, so it's that sensitive. It's as thin as a hair. So nerve root affected in C4-5 compression is C5. Remember, this concept I've explained to death in my spinal anatomy, in neuroanatomy and neurological localization to death. So, because this is, again, it's one of the most common questions. C4, C5, it will be C5. L4, L5, it will be L5. The reasons are different. But I'll go through it again if you haven't gone through those lectures. Basically, the C1 nerve comes out just below the head, then you have the C1 vertebra, then you have the C2 vertebra. C2 comes out between C1 and C2. Then you have C3 between C2 and C3. So a disc affecting C2 between C2 and C3 will affect C3. The problem is that there are 7 cervical vertebrae and 8 cervical nerves. So C8 comes out between C7 and T1. So after that, if a disc affects any tissue, you'd think it would affect the above vertebra, right? There is T2 comes out between T1 and T2. So you'd think that a disc here should affect T2. So sorry, C8 comes out. So T1 comes out between T1 and T2. So you'd think a disc here would affect T1. But what happens is, by now the spinal cord is not as long as the vertebral bodies. So then you get, by the time you come to T10 and below, you start getting the concept of a traversing nerve and exiting nerve. So the exiting nerve exits between L4 and L5, whereas the traversing nerve is present right next to it, but exits right under L5 and S1. So a disc of L4-5 will affect L5 because the exiting nerve from L4 has already exited much higher, unless it's an extraforaminal disc. So in the cervical spine, the lower vertebra is affected because this concept does not exist yet. The spinal cord and the spinal bones are matching in their numbers. By the time you come to the lumbar spine, the concept of exiting and traversing nerves causes again for you to have the same answer. L4-5 compression will lead to an L5 nerve root problem, not because L5 is exiting between L4 and L5, but because L5 is traversing downwards while L4 has already exited, and because those bones are much larger and can accommodate this kind of anatomy, these two nerves. Chiari I malformation, MRI image with symptoms of upper limb weakness and headache. So basically, they've given an MRI image of Chiari I malformation with syringomyelia. Just look it up on Google. I have put it up in my section on ACM in our lectures. Just Google Chiari I malformation radiology. What's important to understand is that Chiari I is a bit hard to pick up in an exam because you are very quick. You're nervous. You have to do things very quickly, and Chiari I almost always looks normal. What will give it away? So if this is the brain and this is the ventricle, and here you have the midbrain, the pons, and the medulla, and here you have the cerebrum, and you have the cerebellum and the cerebellar tonsils. If you had to focus just on tonsillar height, and bone is hard to see on an MRI, so it's blackish. but you kind of can see the base of the skull. You can see this here. If you just had to laser focus on the tonsils themselves, it would be hard to catch, but they must have given us syrinx. As soon as they've given us syrinx, you need to look for causes at the craniocervical junction. It could be atlantoaxial dislocation like this. It could be a tumor of this region. It could be a tumor below as well, which is blocking the flow below, like an ependymoma. But if you have now spotted the very long tonsils, I'm hoping they gave very long tonsils, then you know that this is a tonsillar herniation through the Macrae's line, much below the Macrae's line, and a syringomyelia. So that's what would have brought you to the Chiari I malformation diagnosis. If they had not given a syrinx, then it could just be a Chiari I malformation without syringomyelia, but they wouldn't do that to you. It'd be too torturous, I think, or they might, you never know. But for now, this is what gives it away. Remember, atlantoaxial dislocation is very hard to see on MRI. You don't see it unless there is very gross features called BI, basilar invagination. That same MRI that I mentioned here, and there'll be this, and then there'll be the pons, and there'll be the midbrain. So the same MRI, if there is the odontoid process is backwards, going, C1 is not seen, C2 is seen, and this is strongly compressing the spinal cord, then you can say maybe it's an atlantoaxial dislocation, because you won't see a cerebellar compression. You'll see a compression from in front. That would be a very severe atlantoaxial dislocation, short neck, maybe Sprengel's deformity, maybe web neck, maybe block vertebrae. But most important, they will give you a significant basilar invagination. Otherwise, functional atlantoaxial dislocation is not possible. It's not possible to be seen on an MRI. You need to diagnose it with a flexion extension X-ray and a 3D CT for a rotatory atlantoaxial dislocation. A bit of a higher concept. I don't think they'll ask you that in your MSH entrance test. So they've made it easy for you. They've given you a syrinx. Focus on the syrinx, see what's around the syrinx. Is it an anterior compression, posterior compression? If there's a posterior compression, is the cerebellar tonsil below? And if it's not, is it an anterior compression? Is the odontoid process pressing it? Then it would be a basilar invagination, atlantoaxial dislocation. Or if it's a mass lesion, like a rheumatoid pannus or a tumor or a foramen magnum meningioma. So a question was given on one of our favorite things, the Hunt and Hess grade, Fisher grade, modified Fisher grade, subarachnoid hemorrhage classification. So this Hunt and Hess is the clinical classification, WHO is WFNS is classification, is clinical, and Fisher and modified Fisher are radiological classifications. So I don't know the exact question. They had given the name of a 45, the patient of 45-year-old female suddenly had a severe headache, no focal neurological deficit. So the one thing that gives it away is no focal neurological deficit. That's very important for your Hunt and Hess grading. CT scan images were shown, not sure if angiographic images were shown. For angiographic images, you just need to have to study at least the angiographic anatomy. I have given this in my lectures. Again, I think we should do an atlas for this. Angiographic images of how the ICA looks, how the MCA looks, how the ACA looks, how the PCA, basilar, and vertebral look. And maybe you can spot an aneurysm. If they've given an aneurysm, it will probably be very easy to spot. I mean, they will not give you very small and tiny aneurysms, I hope. And if they've given the fact that no focal neurological deficit is present, then it's most likely HNH2. That is the giveaway. CT scan, you have to just be able to see how much SAH there is. I have given exactly in my lectures how Fisher grade is measured. And especially Fisher is easy, modified Fisher is a bit harder. But here they gave you a question on modified Fishers. As an INI preparer, you need to know both modified and normal Fisher grades, standard Fisher grades. It's not hard. I think the HNH classification is much harder than the Fisher grade. Once you see the images, you'll remember them by heart. Remember, in the Fisher grade, thickness of the bleed has been mentioned. The mistake people think is the thickness of the bleed would be only if you see a bleed that is long. So if it's seen long in a single cut, that's not entirely true. If the bleed is seen as even a dot, but in multiple cuts in the axial scan, then remember it's a 5 millimeter gap between axial scans. So if you see it in even 2 scans, then it's more than 5 millimeters thick, right? It's at least 5 millimeters thick. So that changes the Fisher grade immediately. So remember that. I've mentioned this again in my lectures, but that's one of those few points they play on when it comes to MCQs. So a tumor presents with a seizure, all except other choices have not been given, but low-grade glioma has been expected. Ependymoma again. Now this is the thing. Now ependymomas of the supratentorial compartment will definitely cause seizures. Usually, what the confusing part is, why these two are confusing is ependymomas almost always present in the posterior fossa, like medulloblastomas. They also produce drop metastasis in the spine. So the presentation of ependymoma is rarely, very rarely with a seizure. Low-grade gliomas can present with the seizures. So between ependymomas and low-grade gliomas, it's a tough choice. Low-grade gliomas, although are almost always present with a headache, they also don't present with seizures much. So can an ependymoma present with a seizure? Of course, it can present with a seizure. It's not a valid question. If they give questions, they should have a thing about making absolutes, right? Ependymomas can grow so large that they can go through into the anterior part of the brain. So I recently removed one in a 1-year-old child, 6 centimeter tumor, and they can cause upflow dilatation, causing significant deficits, causing seizures, vomiting. Most importantly, they have drop metastasis. They can metastasize through into the spine, and they can metastasize through that CSF into the entire brain. So they can cause seizures there. Between low-grade gliomas and ependymomas, I think the answer would be ependymoma, because low-grade gliomas can definitely present with seizures, although it is very, very uncommon compared to high-grade gliomas. Low-grade gliomas generally present with long-term headaches. They become very large by the time they're found out. So they are also present mostly in middle-aged or maybe young adults. I mean, in the sense that from 25 to 45 or 50 would be the low-grade glioma age. So between these two, I think ependymoma would be my answer. But again, it's a controversial question. A 44-year-old male patient, a tumor in the white matter. Most likely, now all of these tumors are in the white matter. So I would say the answer would be low-grade glioma. I just mentioned this in the previous question, that the average age of presentation for low-grade gliomas would be middle age. So it will be 25. I'm saying 25 because I've seen patients repeatedly in the 25 to 28 range presenting with low-grade gliomas. 30 to 50 would be the standard period for low-grade gliomas. GBM definitely much older, after 60. So the answer would be low-grade gliomas. Metastasis again from mostly cancers, and those also present much later. Tumor with IDH mutation, 1p19q co-deletion, and what is the treatment? So when you talk about 1p19q, very easy question. It's an oligodendroglioma, an ODG. IDH mutation has also occurred. Also, it's a glioma, and it's 1p19q co-deletion, which means that it is an ODG, oligodendroglioma, and it is very, very amenable, to targeted immunotherapy. Now, why it becomes a controversial question is because the choices given are chemo immunotherapy, chemo plus RT, chemo plus targeted therapy. So RT is almost always given. If it's an ODG grade 2, even with full resection, I mean, I did an African patient about last week, ODG type 2, and we sent him for analysis and 1p19q co-deletion, everything. RT is recommended. You have to give RT. Now, according to the choices given to me, was only one with RT in it. So it is chemo plus RT. Now, immunotherapy is a targeted therapy for 1p19q co-deletion. So the answer is actually, the targeted therapy is D, but the targeted therapy is immunotherapy. So that's B. It's definitely not only chemo. You have to give RT, which is why this is not a good question. If you found this question, and you know why these questions have come, because a lot of neurosurgeons have made these questions and published them as MCQ books. I can name a few. I don't want to name people. I've read those books, and their own logic is very, very controversial. And when the makers of the paper pick up these commercial books and they just pick it up and give the answer, they're not putting much brains into it. And I have analyzed these questions significantly, found so many errors in the making of the question that it's hard for me to give you a straightforward answer. So it would be, according to me, to be chemo plus RT, because radiotherapy has to be given. in an IDH mutation 1p19q co-deleted ODG. You would never not give radiotherapy in an oligodendroglioma, never. It's always given. So if there's only one choice with radiotherapy, you give radiotherapy as the answer. A more specific thing would be chemo plus targeted immuno plus radiotherapy. That is the thing. And there are various regimes now. Earlier in my time, it used to be platinum-based therapies that do very well with 1p19q co-deletions. But now the NCCN guidelines have significantly changed. They keep changing every year. So you can study the latest NCCN guidelines. Just type NCCN guideline for oligodendrogliomas. But RT is unmissable. You cannot not give radiotherapy in oligodendrogliomas. Again, it depends on the grade. Grade 1, you may consider not giving RT, but then but immuno is definitely given. But grade 3 ODGs, not giving RT is a crime. So they have not given the grade. So my answer would be chemo plus RT. That would be the right answer. But the other choices are not bad. So it could be chemo plus immuno, because immuno is the targeted therapy. What is the site of fibrous dysplasia with refractory epilepsy? Occipital, parietal, temporal, frontal. The answer is actually common sense. It's temporal. It's not about fibrous dysplasia. You see fibrous dysplasia everywhere. The most common locations by far that I have seen in my experience are fibrous dysplasia of the sphenoid wing and the paracellular region. It's very, very common for some reason. The second I have seen it is in the frontal bone, and the third in the parieto-occipital bone near the mastoid sutures. So, but if it's in the temporal bone, it produces seizures because the temporal lobe is the most common area that causes seizures. That's why mesial temporal lobe sclerosis, herpetic encephalitis of the temporal lobe, temporal gliomas all present more commonly with seizures than any other symptom. Because the temporal lobe essentially is highly seizurogenic, and the answer is temporal. Okay, so patient has an RTA. Trauma to the temporal region is present with GCS of 11 on 15, along with hemiparesis and pupillary dilatation. Someone has written Kernahan's notch, so maybe they're testing you for Kernahan's notch. While waiting for CT, patient suddenly deteriorates. What's the cause? And the cause has to be uncal herniation. So see, the patient has an RTA, so there is edema, mass lesion, whatever. Trauma to the temporal region, that's sign number 1. When you see herniation syndromes, this is the frontal lobe in an axial scan, temporal lobes, occipital lobes, seen from above, all right? This is the brainstem. This is what you have to protect. If the frontal lobe is damaged, it leads to downwards pressure, right? Downwards pressure. Often frontal contusions and frontal trauma, often, and this you will realize once you lose your first patient with this, they do not present with GCS in going down from M4, M3, M2, M1. There are M6 patients who will talk and arrest in bifrontal contusions. They will suddenly sit up with a large headache and suddenly arrest, all right? Even the tiniest bit of mannitol at that time will help those patients. Their BP will suddenly shoot and then suddenly go down, and people will say, don't give mannitol, but it's actually the compression that's causing it. By the time you get them to the OT, they're already infarcted. That's why it's very important to remove frontal contusions on time. The uncal herniations will give the usual picture of patient going from M5 to M4 to M3 to M2 to M1, because the swelling is lateral, usually more gradual, coming from the temporal lobe, sometimes from the frontal lobe, causing a midline shift, and that midline shift will cause the picture of this pupillary dilatation and hemiparesis. So for a hemiparesis, you need one-sided a unilateral lesion. That unilateral lesion now unilateral lesions can cause both subfalcine herniation. So the frontal contusions I'm talking about are central herniations. They push downwards. Transtentorial herniations are central herniations, another name for central herniations. Uncal herniation and subfalcine herniation. Now subfalcine herniations will essentially slowly push the brain under the fox cerebri, while tentorial herniation will push the patient laterally. So both can happen. So this can happen in both subfalcine and uncal herniation, but they have specifically mentioned temporal region trauma. So if it's a temporal region trauma, it is unlikely to cause subfalcine herniation, because the frontal lobe is above and the fox is here between the two frontal lobes, and it will push the brain under the fox, whereas temporal lobe is here and this is the fox. It will push laterally to the brainstem directly. This will lead to third nerve palsy as an early sign. Hemiparesis can happen in both. Hemiparesis is more common in subfalcine though, and but it can happen in both because brainstem compression will also cause essentially hemiparesis at the midbrain. And finally, pupillary dilatation is Carnahan's notch phenomenon. So the answer to this would be an uncal herniation. As soon as they said trauma to temporal lobe and poor GCS, you think uncal herniation. Actually, it's not. It's a no-brainer once you get these two. An RTA case is present. Burst fracture of dorsal spine compressing the spinal cord with all four limbs, weakness, no movements against gravity. What is the management? So there's an RTA case. There's a burst fracture of the dorsal spine compressing the spinal cord, and all four limbs are weak. So there is no movement against gravity. This is not, so the choices are different, but this is wrong. Why is it wrong? Tell me why the question is wrong. So think about it for a second. It's a dorsal spinal burst fracture, but somehow all four limbs are weak. How is that possible? The lowest level, I did day first a C7T1 fracture dislocation, and it had produced with classical central cord syndrome. The hand grip is weak, the elbow is okay, the shoulder is okay. So a dorsal spinal fracture will lead to paraparesis. All four limbs cannot be weak. Unless it's such a massive fracture that the edema has gone up to the cervical cord, by then the patient will already be on ventilator and there will be phrenic nerve palsy. So this question doesn't exactly make sense from the clinical localization point of view. It doesn't happen. If it's a dorsal spinal fracture, then it has it'll only produce bilateral paraparesis. But it will not produce an upper limb weakness. Let's assume the question is a cervical spinal fracture. The management would be, well, high dose steroids have to be given. That's the first line of management. And there are trials and controversies, but in general, the standard practice is to give methylprednisolone. You give a loading, and then you give a maintenance dose, and it has to be given. There is no evidence not to give it yet. It's not harmful, as opposed to giving steroids in trauma, for which the crash trial had produced clear evidence that it's not only not useful, it's harmful to the patient. There is even now no evidence to suggest against the use of methylprednisolone, although the benefits are controversial whether it actually benefits the patients or not. This is wide trials that have been tried, but it doesn't harm. At least that's what come out. So the answer would be high dose corticosteroids. Now the other thing is immediate belt application, and the third would be surgery. So again, they've not mentioned where the belt application thing is strange, because you apply the spine board and the belt at the site of the trauma itself, where you can't give medications. Ideally, these patients are wheeled in on a spine board, right? At least in good centers. If you find a patient who is not wheeled into a spine board, then the first thing you do is put a spine board. You don't put a belt. Exactly. So if a patient is supine, they generally don't require a belt. And if it's a cervical fracture, you just put a collar, right? Now, ideally, the first thing at the site would be to put in a spine board, which has a sort of belt-like function. It's not even a belt, it's a spine board. They've not mentioned the word spine board. They've mentioned belt application. My answer, treatment management, would be high-dose corticosteroids. High-dose corticosteroids would be the first thing that you would do as soon as this patient comes in. You give them the corticosteroids, you put them on a spine board, that's about it. Belt application is generally used for rehabilitation. These patients are generally told to lie absolutely flat on absolute bed rest till the time they get operated. Once they are fixed, you can make them sit, stand, do whatever, depends on your strength of fixation, your extent of momentum, and your own confidence. My answer would be high-dose corticosteroids is as the first step. Immediate belt application is controversial, but usually it is not done in the it's done in the site of injury, and it is done with a spine board, not a belt. Because if you roll the patient even and to put on that very, very cumbersome belt, that itself can cause further problems. So if they written spine board, I would have said spine board first. But if you see a patient lying flat, I think you just keep them flat and give them high-dose corticosteroids. And then surgery, of course. Old male patient, history of fall 2 months back, presents with disorientation. CT shows SDH from frontoparietal region. What's the treatment? Old male patient, history of fall 2 months back. presents with disorientation. CT shows SDH or what treatment. So the answer is tube holes, frontal and parietal for chronic subdural hematoma. This is a classical, they've described the mechanism of chronic subdural hematoma. So the mechanism is usually old patient, that's clue number one, that is chronic. Second is trauma, usually more than 3 weeks old, which then leads to symptomatic subdural hematomas, chronic subdural hematomas. Disorientation, so this patient is not having raised ICP signs in the classical sense. They don't have vomiting, blurring of vision, comatose state. That happens much later. It starts off with hemiparesis, facial paresis and disorientation, particularly if it's a left-sided chronic subdural hematoma, and the treatment is tube holes for chronic subdural hematoma. So what they're doing is just checking if you know the mechanism or not. Again, in NEET as well, they had multiple questions on CT pictures of EDH, which is a biconcave lesion, SDH on a CT, which is a banana-shaped lesion, seminal lesion, contusions, cloudy intraparenchymal lesions, subarachnoid hemorrhage, which coat the brain. If you are preparing for INI, this is not a question I need to waste my time on. It's there in the lectures. If you can't answer this, then you need to study a lot more. Uncontrolled seizures with drop attacks treatment. So uncontrolled seizures with drop attacks would be a corpus callosotomy, I think, because this would be a hemispherectomy would be an overkill. Drop attacks are very specific to specific diseases. One is a hypothalamic hematoma. Usually these are midline lesions. Colloid cysts are the classically described lesions producing drop attacks but not seizures. So if it's an uncontrolled seizure with a drop attack, then usually it would be something to do in the midline, hypothalamic lesions, hypothalamic hematomas. You just remove the hematoma. Rarely would I have seen an aggressive procedure like a hemispherectomy for this. A corpus callosotomy would be good enough. So hemispherectomy is a lot more than corpus callosotomy. You remove the corpus callosum, you remove the temporal lobe, you do a hippocampectomy, you do a amygdalectomy, you do a lot more in a hemispherectomy or hemispherotomy. A corpus callosotomy just divides left and right brains, and it should be enough for uncontrolled seizures with a drop attack. I've done a lot of epilepsy surgery, and in epilepsy surgery usually you still just find a focus, and when you find a focus you do a lesioning or a disconnection from that focus. Even MTLS in many circumstances can cause drop attacks, although sometimes they're difficult to differentiate between drop attacks and the seizures themselves. So uncontrolled seizures with drop attack, my answer would be corpus callosotomy, but again, it's rarely done for this kind of seizures. Usually you find a target. Hemispherectomy, definitely not. It's done for things like Rasmussen syndrome. It's done for uncontrolled seizures. Drop attacks have nothing to do with hemiparesis, with very poor quality of life, with multiple porencephalic cysts where there are multiple foci but primarily lateralized to one side. What is selective dorsal rhizotomy? You cut specific nerve causing spasticity. Yes, that's the answer given. I mean, someone has chosen the answer. I have not given the other choices to me. So let me describe this a little bit. We do this for spasticity. I do it a lot for a lot of my stroke patients, for cerebral palsy patients, for brachial plexus patients, and for a lot of our international patients who come with all of these conditions. So dorsal rhizotomy is basically you open the cervical spine or the dorsal. You open the dorsal spine. For dorsal rhizotomy, toward the dorsal spine. You open the cervical spine for a brachial plexus injury to remove causalgic pain. I'll come to that. That's called. So dorsal rhizotomy is also called a rhizotomy because it is a dorsal root entry zone incision. How you do this is, it's actually fairly simple once you get used to it. You go to the dorsal spine, you open the dorsal spine, and this is the dorsal spinal cord. Okay, you've opened the dura. You have the dura is on the sides now. You have 3 0 sutures. Splaying the dura open, and you can see the spinal cord in the dorsal spine. Now, the dorsal spine has dorsal spinal rootlets. So you're seeing the spinal cord from behind, right? And it has anterior rootlets that then go and form the ganglion here, and then they go and form your spinal nerve. So The anterior columns contain the motor power, the dorsal columns contain the entry to the sensory nerves, right? The posterior columns, pain fibers, etc. What you do is you find this line where the rootlets are there. Rhizotomy is actually the division of these rootlets. So one way to do them is to divide the rootlets themselves, and this is selective because you're only doing these segments that correspond to the area of spasticity. So the most important part, it's not a difficult surgery after a while when you realize, the most important part is to localize where the spasticity is happening, which muscles are actually spastic, and what is the root localization of those muscles, so that you only open up and destroy these segments of rootlets which are taking in sensory information for this spasticity. So you cut these dorsal roots, and you have the advantage of electrophysiological monitoring. You take a stimulator, you place the stimulator on the dorsal roots, and the muscles that it controls, which are pre-marked, we cover them with sterile but plastic sheets so we can see the muscles, usually done in children, cerebral palsy, so it's not that hard. So the muscles are covered, they will twitch. The aim is that the tonal reflex arc is now interrupted. You interrupt the sensory information, and then you don't get the same tonicity pattern, because high tone is what causes spasticity. Because you're not destroying the ventral fibers, you're not actually causing weakness or paralysis, although these muscles are often very weak already. So the chances of weakness or motor paralysis is less. You're destroying sensory input. It does cause often significant numbness, but it significantly improves their gait, balance, etc. Now, there is a similar procedure that we do in the cervical spine, dorsal root enterosomotomy, for causalgic brachial plexus pain. What happens in the brachial plexus pain is that these rootlets are avulsed. You see it's crazy. You'll do a laminectomy, open the dura, you find these rootlets is floating around in CSF, right? And there is a line where they enter from, and you take, there are various ways of doing it. Some people take sharp, narrow bipolars. I do what I have been taught and take a 11 number blade and insert it about 2 millimeters. That's it. It's very fine. You have to make just 2 millimeters, and I make an incision in the respective dermatomes which I need to make, and I will slowly divide the root entry zone. And then you can use very, very, very low, like power of 1 or 2 cautery on this area in the spinal cord to further make sure that the result is sustained. And what that does is the sensations of causalgic pain, which are happening because the root is already avulsed, but because of this neuroma formation and because of the scarring, the patient constantly feels a burning, it's debilitatingly burning pain in the arm that is not working. So that goes away. It gives excellent results. Almost immediate results are almost 80-90%, and it sustains over years for about 70-80% of patients. Similar procedure, one is done for spasticity, one is done in the cervical cord for the brachial plexus for pain, causalgic pain. But dorsal rhizotomy, both are dorsal rhizotomies. One is done in the dorsal spinal cord for spasticity, and the other is done for causalgic pain. So here the question is dorsal rhizotomy for spasticity. Surgery for spasticity, and the question was done, and all of these are there. These are all answers. I've done Botox, my friend does, neurologist. Then baclofen pumps, rhizotomies, like I just mentioned. Baclofen pumps are very interesting. So it's just you do a trial, and then you place essentially what is a large catheter as in lumbar puncture, and you just place it deep, and you bury it into a battery plus a pump, which can be refilled percutaneously with baclofen, and it constantly gives baclofen and reduces spasticity. Rhizotomies work better, very honestly, more permanent, but they contain the risk of severe spasticity of numbness in the patient. So if they are ready to accept that, it's more permanent and definitely cheaper. Baclofen pumps are 17 lakhs. So yeah, big difference. Paraspinal abscess has been shown confirmed tuberculosis after 6 weeks of anti-tuberculosis medication, but patient still has lower limb weakness. There is anterior vertebral body compression. Next step would be decompression plus stabilization and continuity will be managed. So there is a paraspinal abscess. TB has been confirmed, but even after 6 weeks of anti-tuberculosis therapy, the patient still has lower limb weakness. So the question is a bit wrong, because if you find a patient with lower limb weakness where you can demonstrate that there is a spinal compression, the lower limb weakness has to be because of spinal compression. Otherwise, there would be generalized weakness and severe pain. Tuberculosis causes severe radicular pain. But weakness will come if there is a severe radiculitis and a compression of the nerves. Then you're already late in doing the decompression. That is the criteria for doing surgery in tuberculosis. Otherwise, you do not want to operate in tuberculosis, because if you operate in tuberculosis, you decompress the spine, it's usually not enough. The spines are very poor, very weak, very fractured, and you've destroyed the posterior column of the 3-column theory, causing instability. So you often have to fix the spine. And you do not like placing screws in a spine that's already infected. You might make the infection worse. So the answer is decompression plus stabilization and continued tuberculosis therapy. You get a sample from the decompression and stabilization. You can run it for a gene expert. It comes out negative after 6 weeks of TB therapy. You can get, but if possible, if it comes out positive, you can get antibiotic resistance in the sample and treat the patient better. You can also do it from a CT guided tap of the spinal abscess, which is usually done to confirm the tuberculosis, which they have mentioned. But already you've been given AD for 6 weeks and patient still has lower limb weakness. That means you're already negligent and you've already wasted the patient's time and caused severe harm by not recommending surgery earlier to save those nerves that have now been suffering for 6 weeks. So the answer is B, but I'm telling you, this person is already late. Seizure due to hippocampal sclerosis. The treatment is this amygdalohippocampectomy plus anterior temporal lobectomy. Now, okay, so you would say it would be only amygdalohippocampectomy. Why not? Again, hemispherotomy is very, very overkill. Corpusculotomy has nothing to do with the hippocampal treatment seizures. The reason is that mesial temporal lobe sclerosis, which is also hippocampal sclerosis, has a significant anterior temporal lobe component. It is almost always clubbed with the anterior temporal lobectomy, which has significant benefit in preventing the spread of the seizures, even if you just do a disconnection of the amygdalohippocampus, right? So it is a combined procedure. I have never seen an independent amygdalohippocampectomy. I have seen lesioning of the hippocampus. Okay, you can these days put electrophysiologically guided radio frequency ablators directly to the hippocampus and perform a lesioning. It has been happening for a very long time. Now it has gained new light in the usage of robots for this, which is happening in some of the advanced centers. I've not seen the robotic work, but I have seen the radio frequency ablations. But if you're doing a ectomy, which is a removal, it is almost always done with the anterior temporal lobe. You have to go through the temporal lobe to get to the amygdala and the hippocampus. It's usually utilize the ventricular anatomy, which is the temporal horn of the lateral ventricle. You enter it, and there you can see the hippocampus, the impression of the hippocampus, and you have to dissect medially and above from there to reach the amygdala, antero-superiorly. So essentially what happens is you end up doing a anterior temporal lobectomy, enter the ventricle, go in, trace the hippocampus. Always good with navigation guidance, difficult without navigation guidance, not impossible. I've seen it, done it, but difficult. And you can end up screwing up a lot, and you can end up not being accurate. So you go in and anterosuperiorly, you will find the amygdala. You have to not take out the entire amygdala, right? But you can do a amygdalectomy anteriorly, and you can do a hippocampectomy up till a certain point. The tail is usually left because it causes severe emotional disturbances and other imbalances. So I've almost never seen it done being independently. So my answer would be this, and I think I've seen this question before, and the answer was C. Difference between CSW and SIADH. Very, very common question. We have dealt with this in hyponatremia and hyponatremia, sodium balances. So CSW is cerebral salt wasting. It's essentially a dehydration. So this commonly occurs in SAH. Right, in traumatic SAH particularly, we can see in 8% of cases CSW, and SIDH is syndrome of inappropriate antidiuretic hormone secretion. Often it is seen in the triple phasic response after pituitary surgery. That is, I think, the most common thing, but it is also seen in aneurysms and others. Difficult to differentiate. CSW is a dehydration, whereas SIADH is a sodium excretion. It is throwing out sodium. So, basically, the difference is from the volemia. The volume changes will decide whether it is CSW or is it a SIADH or inappropriate antidiuretic hormone secretion. So, if you have too much, if you have too little antidiuretic hormone, you get what? You get diabetes insipidus. If you get too much antidiabetic diuretic hormone, you absorb water from your renal tubules, and therefore that excretes too much salt and removes the water and brings it back into the system, causing hypervolemia. Whereas in cerebral salt wasting, you lose both water and salts. Think of it as a dehydration, as if you've played sports for a very long time and you've lost both salts and water, causing hyponatremia. So, CSW will have hypovolemia, while SIADH will have hypervolemia. I've not even seen the other options. So, low serum sodium, both have high serum sodium. High urine sodium. High urine sodium will be there in both, because again, SIADH will excrete, so will absorb water, so there will be high urine sodium concentration. CSW will excrete both water and sodium, so it will still have high urine sodium. Answer is hypovolemia. What is seen in the brain in brain death except absent pupillary reflex? Check. Absent corneal reflex? Check. Absent deep tendon reflex? No. Absent Dorsal reflex? Check. So, absent deep tendon, why not? Because deep tendon reflexes are spinal reflexes, and you get what is the Lazarus sign. Forget about brain death, you get Lazarus sign even after clinical death. There was a very famous case when my father was in school in Calcutta, where there was a person who was diagnosed as dead, and during the funeral procession, when he was being carried to the funeral pyre, he got up, and it caused a big, massive riot, and the family members went and burnt the hospital because they were so angry. That was Lazarus sign. It also happens because decomposing bodies can actually gain gas inside the stomach. That's the other theory, and that can cause stimulation of the spinal cord, causing the Lazarus reflex, and that Lazarus reflex can last the tone can last a very long time. So it led to the person just getting up from the bamboo that they were carrying the patient on. It is also very important that as a person who declares brain death, which I've done many times, to tell people that, especially for organ donation and transplantation, that this movement that you're seeing on rubbing the leg is not that the patient is not brain dead. It's important to differentiate. Sometimes it's so strong that you pinch the ear and you see a leg response, and you would think that, oh my God, this patient is M4. No, you've pinched it and you've pulled the neck just slightest amount, and that slightest amount is enough to cause a severe Lazarus response. So when you give pain stimuli above cranial in a patient checking for brain death, you have to be very sure you're not moving the cervical spine at all. Give it directly downwards or up front. Even this, imagine pressing it downwards, you're actually pushing the cervical spine down, again causing Lazarus reflex. So you have to be very careful on what pain stimulus you give. So deep tendon reflexes are not essential, absence is not essential for brain death declaration, the rest are. Multiple cervical spondylosis with disc listhesis and compression over C5-6 with symptoms. The treatment is, so it's multiple discs. There's compression over C5-6. There is, so there'll be laminectomy. I don't know. They've got laminectomy. I do not know. ACDF, multiple. So I've done and seen multi-level ACDFs, not particularly recommended. What they're describing is basically what they're describing at multiple level spondylosis is basically cervical canal stenosis. The treatment is usually a laminoplasty. In fact, if they're given a laminoplasty as an option, that would be the answer. They've also given listhesis. Now, listhesis, I would not do a laminoplasty. For listhesis, you would do a fixation. Sometimes these patients require a 360-degree fixation. You go in the back, you go in the front, you do both. They don't want to make things so complicated, thankfully. So what you do is, they've given simple choices. The answer would be a laminectomy. Now, this laminectomy for listhesis there is nothing like disc listhesis. The disc protrusion is present. Listhesis is when the bones have listhesed. In such cases, I would always do a lateral mass fixation at least, which would be a posterior fixation of the cervical spine to prevent further listhesis. But you have to do a laminectomy. As ACDF, they're not given number of levels, but laminectomy, you can assume at least decompresses the spine in all the involved levels. So the answer to me would be laminectomy. Treatment for traumatic brain injuries all except corticosteroids. We just discussed this, the crash trial and everything else I just mentioned in a previous MCQ. Corticosteroids is not given for traumatic brain injury. There are both that. This is wrong. These are wrong options. 0.9% NS, it's supposed to be 3% NS. That's the treatment. So 0.9, if they've given, they're all wrong. So it should be all of the above if there's an all of the above option, because 3% sodium chloride is a decongestant. 0.9% sodium chloride is just NS. So I guess they're saying you treat the dehydration. They're giving some non-specific treatment. So I guess, yes, we do give normal saline to patients, so that's not wrong. But if the actual treatment is 3% NS, which is considered superior to mannitol, especially in kids. So, but corticosteroids definitely is a no-no, right? That's the answer.